Thank you, Dr. Levine, for that powerful and insightful message. As she reminded us, achieving health equity requires not just intention, but collective action. The People and Places Thriving Initiative and the focus on vital conditions offer us a clear path forward, one that prioritizes not only individual health, but the well-being of entire communities. Our first panel today will focus on addressing the vital conditions for cardiovascular health and well-being, origins and opportunities. Dr. Bobby Milstein, Director of System Strategy at Rethink Health and the Ripple Foundation, and a cutting-edge thinker and innovator in population health for most of this century, will facilitate all three panels today, guiding us through discussions that delve into the heart of these issues. Following each panel, we'll open the floor for a Q&A session, so I encourage you to think of questions as the conversations unfold. Dr. Milstein.
Well, thank you, John, and thanks to the National Forum for creating such a terrific space to explore the implications and opportunities for organizing around vital conditions. This is the first of three panels, all inspired by what we've already heard in a keynote address from Admiral Levine about why so many federal agencies are organizing their work around vital conditions and getting into different relationships with people and places all across the country. So we're going to explore in this session three big questions, and we've got three terrific colleagues to do it with. I'm joined by Dr. Ruth Thomas-Squantz from the Build Healthy Places Network, Dr. Shoma Saha from We in the World, Wellbeing and Equity in the World, and Bern Melnick from the Ohio State University and incoming chair of the National Forum. Together, we're going to explore some basic questions about what is the vital conditions and how does it build on what many of us think of as social determinants of health. We're going to spend most of our time thinking about the motivations that are driving growing use of this framework, and particularly among those that are focused on equity and racial justice, pulling out some standout examples that colleagues here have all seen in their work, and then we'll think together about the opportunities and obstacles for how to make the most of this framework when addressing the challenges of cardiovascular health. So what I'll do is just begin with a little bit of an orientation around the origins and opportunities around this framework. And the first thing to know is while the federal government has really been focused on this, as you've heard from Admiral Levine, since the pandemic, this framework has grown through thousands of collaborators across the country who have been looking thirsty for new ways of doing this work, and have been teaching us all about sort of the possibilities of thinking and acting differently in ways that bring all of the players who can contribute to equitable health and well-being into deeper, tighter relationship with each other. For our part at my organization is Ripple and Rethink Health. Everything we do is sort of organized around the idea of thriving together through shared stewardship. That means we join with others who want to realize this unifying, measurable expectation of all people and places thriving together with no exceptions. And we recognize that, our health and well-being relies on a system that is not built for everyone to thrive. But even systems fraught with racism, other forms of injustice, can be transformed through shared stewardship. And the key thing here is that everyone can be a steward. Every person, every organization, every network can play, pretty significant roles in shaping those conditions that affect our lives together. And so, with all of these players playing so many different roles, how do we begin to keep to keep the connections and the rising momentum of this work, sort of focused on shared values and shared actions. And this emphasis on conditions has been a part of public health and healthcare history for decades, right? We have known and has been reaffirmed again and again that public health is what we do collectively to assure the conditions in which all people can be healthy. But decades later, we're just beginning to really agree on what those conditions are. There was a big step forward in the era of social determinants, sort of carrying the message worldwide that health is more than health care. But those of us who've been organizing around social determinants have found it hard to bring the full potential of every sector, every organization, and so many different walks of life into unifying action. And it was out of, sort of recognizing some of those strengths, but also shortcomings of social determinants, that a whole cast of characters has, over now almost a decade, been thinking of how can we get more specific about exactly what are the conditions that together we're trying to assure. And that is in many ways what the vital conditions framework has become. It's really a statement not of the experiences of individuals, their own health and well-being over their life course, but the properties of the places and institutions that surround us. Right? These are the opportunities, the obstacles, the exposures, the choices that we encounter throughout our lives from birth to death, but critically across generations. We'll talk about that even in the last few moments here. At this point, there have been hundreds of organizations across the U.S. that have been describing their enthusiasm for this. We now heard about 47 federal agencies, a National Academy's consensus report. There was a commentary published in Health Affairs recently that observed that never before have so many federal agencies and leaders across the U.S. been organizing around the same set of vital conditions. This could be a watershed moment for our ability to move in a direction that, we have always been, let's say, capable of doing, but have never been clear and focused and concerted enough to bring to its full potential. And there's more than just the slogans that are appearing in the graphic. Behind the scenes, there are definitions, very practical definitions for each of these vital conditions. We can begin to see their built-in interdependence and spot those actions that are going to have sort of multi-solving potential, are going to move more than one of these vital conditions through a concerted action. This is not just about funding. It's also the way we communicate. It's the way we measure. It's the way we set policy and the way we shape routine practice. So there are infinite number of ways that we can influence these vital conditions. And there is, as one of our third panel will talk about, new ways of measuring as well. A key feature by design of this is that we're talking about a set of things that all people need pretty much all the time to reach their full potential. We need a thriving natural world. We need basic needs for health and safety, clean air, clean water, nutritious food, routine health care, humane housing, meaningful work and wealth, lifelong learning, reliable transportation. But central to all of those is the we ourselves, right? People have a deep need to feel connected and to contribute. For everybody to feel to feel love as part of a community, embraced for who they are, valued for what you bring. And the more that we expand that circle of human belonging, we can actually build civic muscle to be able to work across our many differences and create things that none of us could create alone. That's how we both satisfy our need for connection and contribution, which is a vital condition, and it explains a sort of pragmatic capacity to be able to make equitable progress in any other of these areas of work. We need to expand that circle of belonging and build civic muscle to do things that we can't do alone. So that's really how we grow the pool of assets over time. We're not working with a scarcity mindset. We're working with the infinite abundance of what it means to bring everybody, every organization into the work that they can contribute into sort of an intergenerational quest to thrive together. Cornel West very famously talked about justice as what love looks like in public. And I like to think that this framework starts to define what that love would look and feel like if everybody were treated as if their lives and their families and their communities matter. So some of the greatest champions of this work are teaching us that we can counter racism, other forms of inhumanity, with love, and couple that with the civic muscle that's necessary to establish systems that are fair by design. This is not the kind of world that we've inherited, but it actually can be the world that we pass on to future generations. And so much of this work, as you'll hear from our colleagues on the panel today, is about asking, what does it mean to be better ancestors in this work, and reckoning with those legacies of justice and injustice that we've inherited, and doing as much as we can on our watch to pass along a movement that is aimed toward thriving together. The last thing I'll say about this framework is that it gets even more clear when we pair the vital conditions with a suite of urgent services. Anybody experiencing adversity might need help, right, in a crisis. It might need acute care for illness or injury. It might be addiction treatment. It might be crime response or environmental cleanup. unemployment and food assistance, homeless services. These are all ways of sort of life saving, maybe life altering experiences for people, but none of these urgent services can create the experience of thriving. That has to come through expanding vital conditions. And when we see both sides of this portfolio, we can think about the intergenerational dynamics that are driving well-being and justice in a plural society. Are we relying on urgent services to kind of alleviate adversity and affliction, or are we investing in vital conditions to unlock our full potential for everyone to thrive while still being there and building an infrastructure to deliver urgent services when any of us may need that? So I'm going to stop there with my introduction. There are a lot of resources that are available to us and all of you in this work, but I want to turn to now Ruth Thomas Squance, who has been a fellow traveler and a kindred spirit in this work. I've learned so much from you, Ruth, and maybe just share with the audience what you're seeing about the motivations that are leading you and your colleagues to emphasize this framework and what you're seeing people do with it.
Yeah, sure. Thanks, Bobby. And thank you to the National Forum for the invitation to speak today. My name is Ruth Thomas Squance, and I am co-executive director of Build Healthy Places Network. We're a national center, and we work at the intersection of community development, public health, and healthcare. We focus on transforming the way these sectors work together to create community-centered investments that can advance health and racial equity by addressing these vital conditions for health and well-being. And our goal is really to create inclusive, multi-sector solutions that can then create community environments that are health-supporting rather than health-opposing. So I think when we set ourselves the goal of achieving health equity, I think it forces us to think about what we mean by health. And we begin to think about it beyond the absence of disease, to think about thriving. The vital conditions for health and well-being can really help support us in this more expansive viewpoint, and also help us look at the levers available to us for making changes. On the next slide, we know that health happens in neighborhoods. And if we look at this next slide, we know that health happens in neighborhoods and that chronic conditions on the next slide, such as cardiovascular disease, are really influenced by people's social and physical environments, as Bobby described. But what we found is that the conditions framework gives us an opportunity to take a systems thinking approach to how the distribution of these factors, the vital condition, how the distribution of them and resources can be skewed away from certain communities along the lines of race, socioeconomics, also geography, and therefore denying opportunities for health and prosperity. And it brings in that concept of spatial justice. So really, just as poor health is caused by those conditions, we know that good health can be facilitated by equitable access to those social and physical environments. And on the next slide, we know that partnerships, are really going to be a key to addressing the drivers of health. So rather than propose a solution, I think, for us that hospitals and health departments become experts in creating housing, become experts in creating transportation, as well as everything else that they're already doing. We really think that for our work, what we want to use this framework for is to catalyze those multi-sector actions and create collaborations that go across sectors in the way that you described, Bobby, that can unlock new potential, I think, for addressing these factors and the underlying drivers of the health inequities that we're seeing. So at BHPN, our focus is on deepening impact through upstream investments in community that will improve overall community health and well-being of residents. And just also to add a note that it's equally true, I think, in urban and rural communities that you have that same sort of impact. So one thing that we promote is that as we broaden that landscape of who is in the health ecosystem, the community development sector is a natural partner for health actors that are looking to impact those drivers of health inequities and to redress the harms that we know have been done by patterns of disinvestment in community that was driven by systemic racism. Next slide. So we collaborated with the National Association of Chronic Disease Directors, the NACDD, and Bobby, you were part of that effort with us, where we held a thought leader roundtable and really trying to build the bridge between these two sectors to advance health and racial equity and explore with national leaders from these sectors where we could dig into what their shared values were and create meaningful change in the conditions. And one of the things that was very clear, these are prominent leaders of national networks. Many health practitioners are unfamiliar with the work of community development. And in order to sort of try and bridge that, we created this primer, which is based on the Vital Conditions Framework, as a sort of a starting point to create these conversations around where we know race, health, and place all intersect, and how new partnerships can open up opportunities for helping patients and clients in their communities. So the community development sector is a multi-billion-dollar sector that comes with assets that is investing in persistently underinvested low and middle-income communities through the development and financing of things like affordable housing, schools, grocery stores, health clinics, as well as small business and job training. So immediately you can see the relevance of those to the vital conditions that we've heard about this already today that have been outlined. All those things show up in the vital conditions. And you can access the primer from this link and we'll share them with you. So if we look on the next slide, we can explore what is in the primer just briefly. That it really explains the vital conditions of health and well-being, which you're all experts in now today, introduces the community development sector as this ready-made partner, and then also highlights some of the roles the public health sector, for example, or healthcare can play in multi-sector partnerships. And just to name a few things of this, like can be being a convener of community-based organizations, having a resource of knowledge and data insights that those in the community development investment sector don't have about where the most health impact could be for where they make those investments. We also include a partner finder that's to help you discover partners in your region who else is working in the same communities as you, but in parallel that you may not already know. And it also has some case studies of successful multi-sector partnerships. And on the next slide, I'll just explore a couple of the, some of the themes that come up from that, from the primer in the next slide. And I can share just a snapshot of those. So some of the activities that community development does that's partnered with public health that has focused upstream. One of them could be like establishing community engagement processes to prioritize the needs and solutions of people most affected. And that sort of gets to the centering of belonging and civic muscle that Bobby spoke about. That is, part of the central part of this framework. And it really drives everything that we do as an organization and really should be driving our solutions to be responsive to communities. The community development sector can get involved in developing farmers markets, community gardens or walking paths, increase access to food and healthy lifestyles. And we know that certain environments create higher vulnerabilities to stroke and risk factors such as type 2 diabetes. And these are all strongly related to environmental factors. They also contribute to mitigating the range of physical and mental and chronic health problems that are associated with housing instability just in itself by creating affordable housing, but then layering on by partnering to apply trauma-informed design to that process. So you can explore this primer more in your own time for some resources that can help those that are looking to get started in thinking about community development. Next slide. I can show you some of the several playbooks that we have that are accessible from our websites to support this kind of cross-sector partnership. And so I've really introduced at lightning speed here the new ways in community development and healthcare and public health can work together. And I think if you go to the next slide, you can partner to move upstream and really use the vital conditions. So I think what we know is that business as usual is not getting us to these goals of health equity. And that I think is because it's a multi-sector challenge. It's really going to need us to have those multi-sector solutions. So I hope I can, encourage people to consider these kind of partnerships. And I think this quote I like from that says, if it give me a place to stand and a level long enough, and I will be able to move the world. And I think multi-sector partnerships can be our lever long enough to help make those changes we need to see. I'll pause there.
Thank you, Ruth. But what a delightful segue to Shoma. Shoma, I think of you as somebody very firmly grounded in where you are and who you're with, but your ambitions are as big as our capacities to dream. So I'm wondering if you can just share your motivations in this work and what you've been seeing in the years that you've been championing this work.
Thank you so much for inviting me, and it is always a delight to follow Ruth in this work and you. So I'm Dr. Shomava Shaha, President and CEO of Wellbeing and Equity in the World, lead a grassroots to grass stems and grass tops connected network called the Wellbeing in the Nation Network that contributed to the thinking around the vital conditions and helped to move that forward in our work. But the identity that maybe I'll come into this conversation with, Bobby, is as a physician, primary care physician and public health person who practiced in the safety net for over 15 years, seeing person after person who, in family after family, evolve their history and experience of allostatic stress, the stress of continuing in poverty and experiencing marginalization and racism and experiencing a lack of those vital conditions and watching as deaths of despair set in and watching as what was possible as you could flip that script, as you could create and build a belonging and civic muscle at the level of a community to change the hope that the community had, driven by youth and seniors coming together to say, what could our community be? At the community health center we were part of, we began imagining, well, what would happen if we saw medical assistants and receptionists as caregivers, as stewards, as you would put it, and actually gave them the tools to improve the health and well-being of our community. And then we measured that using the tools we had at the time, including things like A1C rates and blood pressures, all the things that we would know. We did high-functioning primary care, and we were able to be successful as we did that work. And what that led us to, as we did that work well in healthcare and integrated mental health, did all of the stuff, was that we saw a 40% reduction in all-cause hospitalizations for people with diabetes. And that sounds great, except what we could also see was a fourfold increase in the people developing diabetes and other cardiovascular diseases at the same time. That led me as a doctor to begin to ask, what were we missing? What were we missing in our improvement processes, in our efforts to connect people? And of course, a big part of what we were learning we needed to do already was to address people's social needs, to connect them with food and housing and transportation, one person at a time. But when we stepped back and saw the scope of the problem, the kinds of maps, as Ruth said, that really show that place is a determinant of health, we began realizing that the places, the communities we were in, were missing those vital conditions that you were talking about, Bobby. And that began for me a journey of asking, well, how do we create not just one person at a time solutions that are well organized in a system, but really think what it would take to shift the story in the first place. What would it look like to have a world where no one was marginalized, where everyone belonged, where people could bring all of our collective gifts and assets to solve the challenges of our world together? Well-being and equity in the world exists to build that movement of better ancestors that can create those vital conditions in our communities, in every community, because we believe that those whose voices aren't at the table are the single greatest untapped source of human potential to solve these problems. So what does that look like when you actually put that into practice? Well, I'll share with you that in the context of the pandemic, that meant bringing together people, all calling in the assets of our communities, thinking about public health as not belonging to just a set of people in a health department, but to the wider public as a whole, and especially calling in the assets of our communities themselves. We said, what if everyone belonged and could be a leader of public health? What would they do? And we resourced them to do that. That meant bringing together 10,000 Black artists, activists, Indigenous leadership across the country, farmers and barbers and promotores, and yes, doctors and nurses to all work on this together. We collectively decided to ground this on an approach of thriving, of well-being, and actually asked people what they would need for their well-being and gave them real-time data. Of course, what we saw was that things like economic security and food were of the greatest need, especially in the places where the places were set up without those vital conditions. A really amazing thing emerged, though, as we gave these communities not just permission, but invitation to not be bound by what we needed to get done as a vaccine effort, but instead to be free to imagine what was possible in their communities. And as we introduced tools like the vital conditions and a process of understanding why is it that everybody in our community doesn't have these, what policies and practices are in place that are continuing to marginalize, and what would it take for us to be those better ancestors and to solve these in practical ways, knowing that that wheel of vital conditions actually isn't about separate silos of things, but about things that are connected across the board. What would it look like if we made the solutions bigger to solve the scope, to actually address the scope of a set of connected problems? And that's where the real fun began, because you see some people who could already begin to see that food leads to health and improved health, like we had done at our work in Cambridge Health Alliance. They, of course, were doing policies like food as medicine and healthy opportunity pilots in places like North Carolina. But the problem was that they needed to figure out where to get the food from that would create the best health. And they hadn't yet thought about the idea that if they were, instead of just screening people for food insecurity and providing people with prescriptions for food, if they could see that the very people that they were providing those prescriptions from included farmers and faith leaders from their communities who were trying to help people be healthy, but didn't have the generational wealth to be able to assure that something could change. In fact, what really happened was that the farmers in North Carolina, a set of Black, Indigenous, and Latinx farmers came together. And they asked us, well, what would it look like to change this picture? And because they weren't limited in their imagination, and we could bring in people from across sectors, people who were leading food purchasing in the hospitals of some of our largest healthcare systems, policy leaders that were looking at economics and wealth, USDA leaders, as we began to see that wheel, not as a wheel of problems, but as a wheel of possibility, we began calling in all the people that had a piece. And suddenly someone said, well, wait a minute, if all of the farmers were in cooperatives, bringing together a set of belonging and civic muscle, and we could invest in that, maybe we could purchase from that. And that became a strategy for hospital systems and schools and many others. It turned out that there were farm bill dollars that were not being taken advantage of because there wasn't the fiscal and administrative infrastructure. Someone else said, well, maybe we can build that. And then there was a Medicaid waiver in place to begin to think about how to make sure everybody got food. But the state had never imagined purchasing that food or creating the conditions for that food to be purchased from generational farmers who had been disadvantaged. And so by thinking, how can we do three things at once rather than just one thing? What could be a multi-solver in this region? They began imagining, well, what if we yes, let's screen for food insecurity. Yes, let's prescribe, but actually let's purchase. Let's go all the way to creating economic security for the same people who are in our clinics, maybe as patients with poor heart disease, but instead actually are community change agents who can be who are farmers and growers. If we can imagine them not as poor and weak and hungry, but instead as strong and capable with assets and gifts to offer us, we can actually see that we can do so much more together in creating economic stability while they grow the food that in fact in Eastern North Carolina fed a whole region through the pandemic. What they ended up doing to go beyond that was, as the universities came in, they began training people in regenerative agriculture, and they began imagining what that could do for the climate. And as they understood what had happened to the land and reflected on their legacies of sharecroppers who never got their share and of indigenous farmers who had lost their land, they began imagining an entire process where, as they grew generational wealth, they could begin to actually have the land restored and stabilized for the people who had been generational farmers on the one hand, and who had incredible expertise in stewardship of the land on the other. And that, to imagine that entire sequence of events could happen in 6 weeks, that entire sequence of what I describe as radical imagination of what it would look like if we believed that we were in fact powerful enough to build the legacies that for the next 7 generations, that we can understand how we got here, that we can choose to be better ancestors. And then this little tiny wheel that's so colorful, but has so wisely the words belonging at civic muscle at the center, that could serve as a way to begin to say, let's bring in a movement of better ancestors who will bring our pieces together to change those legacies for the long term.
Thank you so much, Shoma, for bringing us along in your learning journey around this. It's thrilling to imagine that a lot of this came just by asking the question, what are we missing? You were working at the top of your game in many ways with the Cambridge Health Alliance, and then asking what more, and the discovery is so much more. Bern, maybe you can pick up on where your thinking around this work is leading you. Where are you seeing some of the greatest opportunities for advancing the goals of cardiovascular health, through the lens of these vital conditions?
Thanks, Bobby. Given my passion for the integration of mental health to improve thriving health and well-being, I'm going to focus on how we can use vital conditions to enhance mental health and promote cardiovascular health. As incoming co-chair of the National Forum for Heart Disease and Stroke Prevention, I am absolutely delighted to share we are deeply committed to the vital conditions framework. There is currently a mental health pandemic in the United States, with health disparities being very prevalent. We all know mental health can either positively or negatively affect cardiovascular health. But there's a growing body of quality evidence that supports stress, anxiety, and depression affect cardiovascular health. And mental health resiliency is a protective factor for both mental and physical health. One of the domains of vital conditions, as Bobby pointed out earlier, is basic needs for health and safety as a vital condition. And that includes freedom from trauma, violence, and addiction, nutritious food, safe water, physical and mental health, routine physical activity, fresh air, sexuality and reproductive health, and sufficient sleep. A paradigm shift is greatly needed in our country right now. We are a sick care, crisis care, healthcare system. We spend more money on healthcare than any Western world country, but our population health outcomes are poor. So we so need this vital condition framework because health and well-being goes so far beyond just health care. The other thing we desperately need in this country is to reduce the big time gap between research and practice in real world settings. We used to joke back in 2000 when research was done that it takes 17 years to translate findings from research into practice to improve care and outcomes. Another study came out in 2021 that actually showed we reduced the time gap to 15 years in 2 decades. So at that pace, it's only going to take us 150 more years to translate what we know works through high quality research into clinical care, into our communities. The gap between what we know and what we do is lethal. We also need to de-implement what is not based on best evidence. So by shifting resources to the domains in vital conditions, I feel confident we can really move the needle and improve our population health outcomes. On this slide, I illustrated how vital conditions and policy strategies might improve, should improve mental health. In terms of the thriving natural world, we can increase green spaces because we know green spaces that are safe for people to walk in, connect with others, can definitely improve mental health. Basic needs for health and safety. We need to invest in infrastructure to ensure that all people who need it will have access to mental health care, because less than half of people with mental health conditions receive treatment. We need to strengthen school curricula to include evidence-based mental health resiliency building. We have several evidence-based programs that are shown to improve mental health. We teach our children, our teens, all these other subjects. But what is more important than giving them evidence-based cognitive behavioral skills, mindfulness skills, other life skills that will benefit them and protect them the rest of their lives? We also need to ensure all health systems that deliver care to all people, including people of color, implement the highest quality of evidence-based care. In terms of belonging and civic muscle, we need to provide reimbursement for community health workers. We need to ensure group a lot of quality evidence behind it is provided for those who desire it. And in terms of lifelong learning, we need to increase access to addiction treatment and invest in high quality childcare, including the implementation of evidence-based parenting programs. An example in Columbus that was founded by one of my good colleagues, Dr. Pat Gabby, is a program to reduce maternal mortality and adverse outcomes in pregnant women called Moms to Be. It is now in 8 communities in Columbus, Ohio, where pregnant women get together for education and social support. It has shown great outcomes. Now we need to scale that program throughout our entire state and the country. Lastly, I want to provide an example of a signature initiative that was launched by our national forum about 10 years ago. Move with the Mayor has been incredibly successful in building healthy, active communities. And because the forum has recognized how important mental health is in creating thriving, resilient people and improve their overall health, including cardiovascular health, we sponsored another challenge for mayors called Mental Health and Physical Activity Challenge. We had 44 cities in 22 states participate in this challenge. This movement is creating healthier, connected communities. Again, using this vital conditions framework. Lastly, I just want to ask us all today, in the next 5 years, what can we do if we know we absolutely cannot fail with great partnerships and an investment in vital conditions?
Thank you so much, Bern, for reminding us. You've given us some very important keywords here that there is no shortage of things that we can do, right? There's a mounting evidence base. There's a, a kind of engine that produces more and more of the what's we could be able to do. But the why and the who and the how is part of that paradigm shift. You've given us words like movement, right? This is not just a single program or project or policy that we need to enact. We need to be relentless about establishing the conditions that are needed and for everyone to play a role in that. I've heard that in all of your stories, this connection around sort of re-centering on who is doing this work and how we are doing it. So that's, maybe I'll invite us into a discussion about what you're hearing in each other's stories, starting with this idea of the players involved in this work. Each of you have told stories about getting people into a different role that starts to ignite their contributions. We heard it from you, Ruth, about how community development is a ready-made industry that a lot of people in the health, sort of professions do not know what is happening. And Shoma, you talked about the powers of farmers, thinking about what they could do to feed a whole region, but then what that region can do to assure, the healthy environment that is needed to grow healthy food and what that could mean for an economy. And, Bern, you're talking about the role of mental health, for example. There's no slice in the portfolio pie chart for mental health. You need all of these vital conditions, all of these urgent services to tell the story of, are we establishing a society that's built for people to be mentally healthy, and heart and stroke brain health is in some ways a consequence of stacking the deck in favor of people's well-being from the start. So maybe let's just hear what's on your minds after having heard these other colleagues describe the shifting roles of the players who are doing this work. Could go in any order, whoever wants to go first.
We have heard so much negative about the effects of the pandemic and their ongoing nature. What I think we need to do more of, which we have done today, is give examples of the positive outcomes of the work that is being done to create thriving communities and people. I think that's what's missing right now in the media, is just more stories like this to inspire people, to give them more innovative ideas and programs that are based on evidence that work.
Yeah. And Ruth, your primer featured some of those cases. Just can you describe a little bit about what it took to find and spotlight those examples that gave you all hope?
Sure. I think one of the things that we saw was that a lot of the collaboration with public health or healthcare was very downstream. So what you would tend to see would be more direct services. But again, with an asset framing, what we think is that serves as a starting point of the relationship. So you already are working with someone on a programmatic level. It gives you an opportunity to imagine where you could go with that. Where could we go together to move upstream? And it made me think of something that Shoma had said, that question of what are we missing? And I think that having that to build into our practice, that self-awareness to ask, and also then that other awareness to listen, to actually hear from the communities what we are missing, and to help sort of fire that imagination of new ways we can work together.
Yeah, Ruth, I'll build on that. In our work, we say that equity is a path to abundance, that this work happens in the context not of each of us being brilliant, but in the context of each of us being trustworthy, of seeing ourselves as connected to one another, as working with whatever pieces of the puzzle we have, not from a place of deficit, from a place of abundance. And I think that there's something, as each of you were talking, the word hope kept coming up for me. What does it look like for us to show up as hope bringers for each other, as people who value our solidarity of showing up for what each other needs, not just what we need? What does it look like to have a social contract where we know that collectively we each have what we need? And, what you may need and what I might need are different. We may not have them exactly to give each other. But if we build a nation, if we build communities where we can give that to each other, knowing that at some point it'll pass back around to us, maybe we have to stop, not spend so much energy protecting the little tiny slice we have, and instead be able to see a bigger picture, a bigger possibility, a bigger set of solutions together. And, across the country, in places like Arise, what we saw were people for example, of different races, of different ages, at vastly different parts of the political spectrum, be able to get beyond the rhetoric and start asking, what would it take for us to have communities where people weren't suffering, where people were thriving? What would it take for us to bring our assets together to do that? And not what can't we do, but what could we do given what we have today to be able to build communities, and the kinds of solutions we were able to all ask when we went from that, what the problem is, to what the solution is. We're just brilliant and creative and built the possibility of our shared stewardship.
Yeah, I love that example because there's, we've tried for decades to organize around things that we want to prevent, things that we want to stop. We're really just beginning to learn, or I would maybe say relearn, some of the lessons about what could happen when we organize around the things we most want to create. It brings to mind an example of when the Surgeon General, Jerome Adams, who I gather is on the board of the National Forum, right? Every Surgeon General throughout history has picked their issue. And for Jerome Adams, it was the interface between community health and economic prosperity. And there's no accident when you're looking at businesses, not only for, the kind of practices and products that might harm people, but how can businesses be investors and engines of creating the communities we most value? They ended up organizing that Surgeon General's report around vital conditions as well. So it ended up being this transpartisan, trans-sector framework that emphasized the investments that we can make in the things we truly value. And I'm hearing that kind of investment priority theme in your work as well. Ruth, to some degree, that's what community development as an industry.
For sure. Right. I mean, exactly that. If we're talking about looking at connecting systems, and I'm thinking, responding to what Shoma said, Antipon said, what do we have to do systemically to change the way we work in our practices and connect the things that we are trying to do? I think, we can look and understand where something like, I'm seeing the connection already from what has been described about the mental health crisis, the impacts of that on even, chronic disease sort of prevalence. And we know that, for example, the community development sector that is investing in zip code improvement, if you want to say, for a better word, it reduces some of the most common stress factors. It's around affordable housing, reduces financial stress, the stability of housing as that hub for connection to services in terms of reducing unhoused and unsafe neighborhoods. So we can begin to sort of see where our goals and aims in one sector can really be aided and abetted by others. I'm thinking, again, stable housing, the impact on ACEs, that life course element that you had mentioned as already, sort of, Bobby. So I think that it's sort of interrogating our systems as to what are we missing, where can we make those connections, and collectively change the way and where people are experiencing health, which we know is where they live, work, and play.
Maybe we'll end with just a quick round of what you would wish for, what you might be looking for in the decade ahead, right? We've got momentum around this, calling for a paradigm shift. Examples, when we go to know where to look for them, we can find them in plenty. So what do you wish could happen in the decade ahead? And how could the constituency that cares about heart disease and stroke end up being on the vanguard of some of the most important changes that we may be poised to make? So your parting wish for the network of colleagues who are listening here.
I wish that we could reduce that research practice time gap to 0 years. So when we know something works and there's quality evidence behind it, like we know about many of these vital conditions, we invest in it, we resource it, and we make it happen.
I think I would say that, while we're promoting this thesis, this model of cross-sector collaboration, we also have to acknowledge that that takes time and energy, and people are already busy doing their own job. I would love to sort of see the sort of also that investment that Bern referred to in who is the cross-sector partner, who is the cross-sector department of your industry or sector that makes that's whose role is to curate those kind of coalitions, to curate those kind of connections, and help keep this on everyone's as agenda in their sites as to the way that they do work, who will be there to always ask the question, what are we missing, to sort of actually resource that part of the work.
And my hope is that we would develop practices where we were unafraid to look at the past to understand how we got here, unafraid to share what we have, so that those who have been marginalized, whose solutions and assets and gifts can't easily come to the table because they don't have what they need to offer them, and that we would be unafraid.
That's so lovely. And it's often said, one of my great teachers in this work says that we grow in the directions of the questions we ask. And I wish that we keep creating spaces to ask these kinds of questions, to stay on the learning journey that will propel us to the next adjacent action, the next adjacent partner. And that's how we grow a rising movement around the values, the things that we most want to create in the world. We will overcome partisan differences and sector differences. We will negotiate those things, but we shouldn't shrink from our values of shared humanity and that quest to thrive together. So thank you all for your time. Thanks to everybody who's been part of this session. We've got several more panels to come, which will provide even more of those examples of who's doing what, where, and how is it getting measured. So stick with us. The National Forum is providing an amazing space to look at the state of the art in this work. So thank you all.
Wow. Doctors Milstein, Thomas Squance, Saha, Melnick, thanks for a truly rich discussion. We're privileged to provide the space that you just referred to, Bobby, for what I think is a great discussion based on some of the comments I'm seeing from folks. It's one that is highly valued. We'll now open the floor for questions. And please feel free to ask our panelists anything that you'd like to explore further via the Q&A button at the bottom of the screen. I'll note that Bern Melnick she was unable to stick around for Q&A. She's also chairing a summit today on clinician well-being, so doing double duty, but we're very fortunate to have Bobby, Ruth, and Shoma still with us. The floor is open and they're ready to answer questions about using the vital conditions framework to strengthen social determinants of health and advance cardiovascular health for all. Before we begin with Q&A, I want to share my goal for this meeting with you. And that's for you to get at least one idea one strategy or tactic that you can implement next week to enhance your organization's impact on cardiovascular health and well-being. So as you pose questions, you might think, I heard this idea. What else do I need to know to help me share it with my colleagues and take action? We hear many of our colleagues and allies in the quest for health equity say, we've just gotten social determinants of health into the mainstream, at least into the policy, health policy mainstream. And that was a heavy lift. So please, can we not displace social determinants with a new rubric? Now, Bobby addressed this concern a bit in his introduction, but I think it's such a crucial point, one that we hear with great passion. So it bears a little more conversation. And I'd love to hear how each of you view the interplay between social determinants and vital conditions. Ruth, you want to lead us off and then Shoma?
Sure. I think for us, the case I would make for the vital conditions is that they're very accessible. And the fact that it really does open up the concept of the social determinants for those who are outside of the health sector, and to see how they can engage, where they can put their shoulder to the wheel, and where they can work with us to help create environments that support health.
I'll build on that. If you think about it, social determinants of health was language that we have learned to internalize as a sector to shift our mindsets. It was about us reorienting. But as part of that reorienting, if we do this work well, we come in relationship with communities, with patients experiencing inequities who have who have a broader frame to their lives. They're not thinking, what are the social determinants of my health? What communities told us is they really need in their context, if we're to join them in an equitable journey, really their mindset is about what are the conditions we all need to thrive. And the vital conditions, which is why they're grounded in things like belonging and civic muscle. They're really about us having gone on our journey as we've embraced the social determinants, understanding that to change those social determinants, we need to come together as part in community. And in community, we need to build a shared vision for what it looks like for all of us to have what we need to thrive. And that's really what the vital conditions invites us to, in language that's plain and simple, and most importantly, chosen by communities.
Yeah, that's exactly
Yeah,
my answer.
Bobby, before you answer here, let me just say Wendy Bailey really put a fine point on this and asked how are vital conditions are they the same or different from social determinants? I think Ruth and Shoma have addressed that, but if you can put a similarly fine point on that answer, that would be
Yeah, I
great.
love the question, and I'll just pick up the spirit of what Ruth and Shoma have already said, which is that the genesis of this vital conditions framework comes from some of the champions of social determinants discovering what is it going to take to bring more and more people into this work. And one mark of the growing not only mandate but momentum around this is the idea that we have to turn the chapter and be more specific about what it is we're going to do, right? So getting across the idea that health is more than healthcare was an important historical accomplishment. Identifying classes of, drivers that might matter is useful, but this work is now matured to the point where we need to be really specific about what is it we want to create, and the ambiguity about social determinants, but now like which ones and where and with whom and how, it's just too confusing for so many people who are ready to roll up their sleeves and do the work. And so that's the mark of what this sort of, let's say, emerging dialogue in the field is demonstrating, that there are more people ready to act in spaces that they historically haven't. And we can be comfortable with that because there's not just one vocabulary for this field. It depends on who you're engaging with and how. If somebody, is thinking in a very narrow biomedical frame, they may need to understand the whole idea of social determinants. But if you're dealing with people who've been at that work for a long time, maybe their whole careers, now we need to really have a conversation about specific vital conditions. And so to Wendy's question, anybody who understands either framework can crosswalk the two. I can code switch with different colleagues. It's not important that we have dogma about language. It's important that we have frameworks that help us do the work that we're poised to do together. And, too many people who had been, sort of carrying the flag of social determinants were saying this is alienating some of our best allies who aren't really necessarily motivated to organize around health, but they are motivated to organize around thriving, or, the idea that we together could create, a deeper sense of belonging. We can use our civic muscle to do more than one thing at a time. And so this framework is sort of easier for concerted action, because it doesn't put health at the center of the storyline in ways that, have been limiting for this field.
Thank you. Thanks to all three of you.
Yeah, sounds like
so we have
to add more to that.
I was just going to say, I think the other way to think about it beyond language is the social determinants as a what, whereas the vital conditions are a how. They're really are beyond just the words on that wheel, a method of saying, how might we look to understand why everyone doesn't have what they need to thrive and what it would take to get there, which begins with that understanding that we need to be in relationship, that connection and belonging, and that we need to then exercise our shared power and privilege to change the system. And we need to understand that all these things are connected. They're not separate boxes, but in fact, housing and health and our mental health and our job security, our ability and whether we have it, are where we fall in terms of economic or racial disadvantage and residential segregation. All of these things are actually connected. They lead to poor health outcomes and education outcomes and life outcomes. So there's just a way in which the wheel and then the idea of what it means for us all to thrive and how can we really know we are and what it means to create practical change. It's really that set of hows that I think is the biggest differentiator. That's where I invite you all to go beneath just the words that are on the outside of the wheel, which look exactly the same, to know it's really about how we get there.
Shoma,
I love
audience members are giving your answer a lot of love. So thank you, Ruth. I'm going to ask that we put a pin on that or in that because we have several more questions. So let's try to keep our answers brief, and I'm going to direct this question first, the next question first to you, Ruth. It's asked by Warren Jones, and he says, how do you recommend addressing what I would call weaponization of social determinants and health equity in communities? Many communities may be shortchanged resources because of those tactics. And how do we avoid the same for vital conditions?
That's a really great question. And that's just something that we've definitely seen and been responding to in our work nationally. And I think this speaks to the comments that we've had earlier about not focusing so much on the words, but the actions that are associated with those words. And I think what we're sort of looking at, what we're talking about is value-based conversations where you're really reaching mutual discussion by focusing on the underlying values that you are trying to achieve, sort of a collective why that can be the stewardship of why you want to create thriving for everyone in your community. And then the implementation of that is through the social terms of health. So while the words health equity may come in and out, I think the values that underline them are not as divisive as the words that have been weaponized. So I think that we can find mutual bridging between that, from things like humane housing, as Bobby can speak to, is a specifically chosen word. Humane housing is not just any housing; it's a value inherent in that does underpin health equity. But whether you're saying health equity or not.
Yeah, thank you, Ruth. Madele Ogani from Emory University says she would argue that health is not a word that alienates, that everyone wants good health. Does that resonate with you, Shoma?
It's certainly true that everybody wants good health. And I would say that our in our country, people associate health as physical health. And they actually don't think a lot about how the fact that we actually have tons of data now. And my first master's is a fold higher difference potentially based on where you grow up, and decades of life expectancy difference based on whether your community has a vital conditions. I wouldn't have guessed it.
Yeah, that is such a key point. And it's one that we had a panel at last year's meeting that Bobby Jerome Adams led. And one of the key takeaways from that panel was that even in really conservative states in America's heartland, um, they were able, Indiana, my home state, was the example that was given. And they found, these advocates for health equity and public health found that they were able to get everybody on board, widespread support by focusing on what Shoma just alluded to, those differences in life expectancy, even within communities and certainly between communities, and by making the discussion local about people's neighborhoods and their quality of life. So there's a discussion last year, you're bringing continuity to that line of thought and those real experiences. Bobby, I think of you as, when I think of vital conditions, I don't know if this is fair or not, but I think of you as sort of like the Ace Hardware store owner. If I'm looking for a tool related to vital conditions, I'm coming to your store first. So we've had a couple of questions from people. Are there tools to help us use the vital conditions in our setting? I know they're out there. Can you all give just a couple of quick suggestions about where people can find them? And by the way, we will have links on the this meeting webpage, so you'll be able to find some of them there. But I know there are others out there.
Yeah, it's a great question. The short answer is yes, there are tools, and there are not enough of them. So we need to build more of them. We need to make it easier to exchange those tools. Shoma, Ruth, myself, and others are involved in building these tools or curating them, so that what we make it easier for people who are now beginning to orient their work on actually producing vital conditions, have a suite of resources that fit them and their role, and like what their exact circumstances are. There's a lot of variety there, and as a field, we definitely need to build a light enough infrastructure where a new generation of tools can get to the people who can best use them and then iterate and evolve. I don't know anybody in this work that hasn't created tools that they think are finished and final. They're all works in progress, and so the more that we use them, the more that we talk with each other, not about, yes, we need to value vital conditions, but which tools work for whom in which circumstances, and how are we learning about the practice of doing this. That's what's next, right? I mean, and there are networks, the Build Healthy Places Network, the WIN Network. We have a sprawling network of rethinkers. There are lots of organizations at this point. The WIN Network itself is made up of thousands of members who've joined and said, yeah, this is a big part of our work. And it is a kind of learning platform for the field. If it didn't exist, we'd be talking about how do you create it, and it's a movement of movements, right? So there, in some ways, we have a lot of tools. It's hard to find them and sort through them, and that's what's next. We need co-investors to help build, user-friendly libraries of these. The link, last thing I'll say is the link I put in there is to the Community Commons, which is an amazing asset to the field for all kinds of work. A free repository of resources that we all hold in common. And they started organizing their database around vital conditions back in 2018. And there's hundreds of thousands of users of the Commons now. We just need to bring that to the tens of thousands, the millions of us who are, able to do this work.
Yeah, thank you. And we've run out of time for Q&A, but I do want to get one more question in. So let's just take Bobby's answer to the previous question, go with that. I do want to point out to folks, if you haven't been looking at the chat, check it out, because our panelists, in addition to responding in real time to your questions, have been entering links and other information and observations into the chat, as well as a lot of really rich comments from other meeting participants. So a lot of great information and observations in the chat. So I commend your attention there. Shoma and Ruth, the final question is from Kayla Flores Tyndall, who says, I completely understand why the vital conditions in this conversation is related to preventing heart attacks and strokes, but I think many people will find it hard to understand the direct connection. How do you convince people that focusing on vital conditions actually can have impact on downstream outcomes like heart attacks and strokes? And as I said, we're past the time for the next panels, so if you can keep your answers brief, that'll be great.
I can jump in with a quick example. So I often use stories and examples. And one is in a project we're working on in North Carolina. What we're looking at is in a county that has some of the worst cardiovascular outcomes and diabetes outcomes in the entire state, largely rural, small Black community. It turns out it's farmers and the communities associated with them who are growing up in historically marginalized communities, former slaves turned sharecroppers who never got their share, who have the worst outcomes. And those are generational, historic, and related to the conditions they have. When we adopt the vital conditions framework, we can actually understand that if we can shift the way we not just prescribe food as medicine to address heart disease, but actually partner with and fund and resource farmers, Black, Indigenous, Latinx farmers, to be able to build generational wealth, to be able to connect faith communities that are Black churches and women's groups and others, to be sewing circles, to begin to connect them in ways that helps make health and well-being part of what people do. And we resource them to be able to come together to bring the public into the health of the public. Our assets to change cardiovascular outcomes is much higher than if I was in one of the community health centers that's part of that initiative as a primary care doctor, just trying to convince someone in my 10 to 15-minute visit how to eat healthier.
Yeah.
It's really about making the conditions of the community a place where people can afford, buy, and sell and have healthy food be a norm rather than a special thing.
Excellent. Excellent. Ruth, you get the last word here.
Get the last word. I think that is the power of the vital conditions, is that people can really see and understand the set of things that support the work that the health system is trying to achieve in terms of prevention, in terms of treatment, that we know that I think that there's a lot of movement. I think some people may find it difficult, but I think there's been a lot of growth. And from what Bobby alluded to, there's been a lot of movement of people understanding how health is experienced. So I think that the vital conditions is a great framework or tool to get us over that last step and to recruit our partners and our collaborators in achieving healthy communities to support the work we want to do in the health system.
Wow. Terrific. Gosh, I think we have more questions. I think this discussion could go on for another, for a while, and it would be very enlightening. But we do have another panel. We need to move forward. They're waiting in the wings. This has been terrific. So Bobby, Shoma, Ruth, thank you so much for illuminating the vital conditions for health and well-being and how they connect to cardiovascular health and well-being and to health equity, and really look forward to seeing the follow-ups. Shoma, love the stories. That's a great teaching tool. Thank you all so much. Really appreciative.